in clinical evidence synthesis. I'll let him start. Thank you, Joseph.
Okay, well, thank you. Pleasure to be here. I have a lot of slides, so I'm going to be talking very fast, and because I have less than 60 minutes. But feel free to stop and ask questions nonetheless. This article in the New York Times Magazine in December 9th last year has this story. It's called The Year in Ideas, and Encyclopedia of Innovations, Conceptual Leaps, but also includes some harebrained schemes and cultural tremors. And hindsight reckoning in the year 2001 that made a difference. And what the editors and writers did in this issue, where they selected 80 ideas that shook the world, or at least that jostled it a little bit in the year 2001. The fields covered include business, fashion, medicine, politics, sports, warfare, and under medicine, as Lou pointed out too already, one of them is pharmacogenomics, but also evidence-based medicine is one of the topics, among several others. This is a article from the Lancet, published several years ago, 1997, showing the rise of articles containing the keywords evidence-based or evidence-based medicine in the title or abstracts, showing that since 1992, the growth has been very rapid. And if you do a more updated search in 2002, you will see that probably about 1,000 articles a year are being published. And these are some of the publications also in the literature: evidence-based medicine, evidence-based nursing, evidence-based health policy and management, and I think that even a journal for evidence-based pain management or something like that, right?
Is there? Well, they were talking about it a few years ago.
Okay. The politics prevented action. And then there are the books, evidence-based medicine, how to practice and teach. And then the Journal of American Medical Association recently came out with this volume called The User's Guide to Medical Literature, a manual for evidence-based clinical practice. So clearly, there's a lot of activity in this area. But what is evidence-based medicine, or commonly known as EBM? This is a definition by one of the founder of this field, David Sackett, who was and back in Masters now at Canada. Evidence-based healthcare is a conscientious use of the current best evidence in making decisions about the care of individual patients or the delivery of health services. The current best evidence is up-to-date information from relevant, valid research about the effect of different forms of healthcare, the potential for harms from exposure to particular agents, the accuracy of diagnostic tests, and the predictive power of prognostic factors. Well, you may ask, isn't this how medicine is really practiced already? Well, this is a question I'll propose, but this is what I also thought when I was a medical student and a medical house officer. But when we actually look at our practice of medicine, it's more like this. See one, do one, teach one. And it's more like apprenticeship. And that's why we follow our senior physicians around and try to gain insight and whatever intuition. And tradition-based medicine also emphasizes the following: the primacy of knowledge. That's why you go to medical school and cram all the facts, lots of information. And also about experience. That's why we take many years of residency to gain this experience. And hopefully, then we will also gain this intuition and exercising good clinical judgment. Intuition is not something that easily taught. On the opposite side, the evidence-based medicine stresses the following: critical examination of evidence from clinical research of patient outcomes. I will stress this word, outcomes. That is what actually happened to the patients, not what happened in the test tubes or in a surrogate. And also based on systematic collection of evidence in order to reduce bias, not just anecdotal examples that is great treatment. And also rely on synthesis of evidence to try to quantify what a collection of studies inform you. And hence it reduces the emphasis on intuition and also on systematic experience just based on cases. And also it reduces, although that does not tell you to eliminate beliefs on the pathophysiologic rationale, because this is what science is based on. But unfortunately, sometimes this pathophysiologic rationale is what is called surrogates. Therefore, it may not actually reflect what happens into the patient. And evidence-based medicine emphasizes the integration of good judgment along with the best available evidence. Now, what does that mean, best available evidence? I'll discuss some of this. And also, it also incorporates patients' value in making a clinical decision. So evidence-based medicine is not just about what the studies found and so forth. It's integration of multiple sources of information. Now, how is evidence-based used? There are multiple levels how of evidence-based medicine activities. There are producers of evidence, such as clinical trialists, people who does the trial, investigators who conduct the studies. There are synthesizers of evidence, people who conduct systematic reviews, meta-analysis, or people who conduct decision analysis, a method that try to combine multiple sources of information to help you make a decision. And then there are users of evidence. There are many. Patients included, consumers, clinicians, policymakers, researchers. And let me just highlight, to keep this back in mind, some of the steps of practicing evidence-based medicine at a user's level. And most important is that you need to ask the right question, and also formulate a question that's answerable. And I have some examples of this later. And then just go about search for the best evidence to answer your question. And then when you find some information, you also need to critically appraise the quality of this evidence, both the methodology of the research and also whether the study is applicable to the population, the patient they have in mind to apply it to. And then finally you incorporate the information and findings into the decision-making process.
Do you find that insurance companies are now using this evidence-based medicine in utilizing their reimbursement?
Yes. Yeah, actually, they're beginning to. And also, that one of the biggest insurance companies in the country, not the world, the United States government, Medicare, they are beginning to apply this EBM process. And our EPC is actually helping them to evaluate some of this evidence.
Because I know they typically lag behind.
They are still lag behind, but they are beginning to apply this process. And well, when did EBM begin? You can argue that post-revolutionary Paris in the late 1700s, and some of the Paris physicians, proposed this approach. And if you dig deeper, maybe perhaps there may be some literature suggesting that even in BC China, there are some physicians talk about that. And McMaster University coined this term, actually, evidence-based medicine in 1992. And since then, this is when it actually took off as entity. But some also may argue, so this is perhaps a French wine in your Canadian label, perhaps maybe a sour grape in there. What are some of the common reactions to EBM? What is it? There's nothing new. It's dangerous. It's cookbook medicine. It's not practical. It overemphasizes on randomized trials, and perhaps it's a way for managed care to limit practice. And why do we need EBM now? Well, because of managed care and also cost, we need better accountability. And in order to account, obviously, we need to quantify the outcomes. And there are also many effective treatments now only in the 2002, no longer in the 1960s. And there are many alternative treatments. And then there are costs involved in each of the treatments. And then patients' expectations also are different now than before. And also, there are a lot more information now. There's information explosion, so therefore there's a need to synthesize information and provide it to the clinicians. And the changing nature of patient-physician relationship. So how we got along EBM so far? Well, a few effective treatments. And many of the conditions also are self-limiting. It doesn't matter what treatment you got better. And whether the treatment actually works or not doesn't really matter. You know, when you go see a doctor, the doctor gives you something, you got better. So and also in the past, lower expectation. And also, clinician, being trained as scientists, rely on this a mechanistic view of the world. And this frequently is a preference for causality model. That is, you would like to believe that something works because of this principle. For example, antibiotics is given to kill some bacteria, so therefore it is safe. You know, it treats the infection. Or similarly, a medicine is given to heart failure if it improves the heart function, contractility, so therefore it must also lead to better patient outcome. But what it does, it does not. You know, unless you actually study it, it's not clear. That is, does it really save life? Does it really improve patient quality of life? More than just improving the cardiac output and so forth. More than just tuning up the numbers. You also must be sure that actually does what it claims to do. And then the knowledge of clinical epidemiology did not keep up advancing knowledge about basic science. As Lou alluded to earlier, that now we have pharmacogenomics. There's very little study about the pharmacogenomic and what is it really does. Even though that some of the tests are beginning to be available to try to predict whether a patient responds or not. But again, whether it really works well, we don't really know. And then finally, the traditions in medicine often die hard. It's difficult to change things. This is a diagram from a letter published in the New England Journal of Medicine in 1978, showing the weight of the medical knowledge. This author went to the medical library with a scale and weighted the index medicus. And the vertical scale is in kilograms, 0 to 35, and the horizontal from 1879 to 1977, about 100-year span, showing that the weight of the medical knowledge hasn't changed much in the first 50 years or so, until around after World War II, then the growth of a weight of medical knowledge exploded exponentially. And nowadays we probably don't want to measure this in kilograms. Gigabytes are more like metric. And to put it in a more personal way, this is the junk mail collected by a emergency medicine physician in San Francisco over a 1-year period. It measured over 2 meters high and weighed 122 kilograms. This is how much, on the average, I guess. This diagram shows what is known as the index of interest. That is the number of papers, articles published per 1,000 cases. Some of these conditions listed here are from very rare conditions, such as the CJD or cruel disease or mad cow disease, a very rare condition. And to more very common conditions, varicose veins, hemorrhoids, cataracts. So for very common things, you have not many articles being published. And yet, on the very rare thing, like CJ Kuru or myasthenia gravis is another rare disease condition, Crohn's disease, you have a very high level of interest among investigators. And for more important and uncommon things like heart attack, stroke, you're down here in the middle. And what is the appropriate index of interest? Well, it's not quite clear. Perhaps because it's just a common condition, maybe we need more studies, more research in this area to optimize outcomes. But this is not how the research are being done. Research are being done on interesting rare conditions. With all this information, where do doctors get the knowledge? This is a survey of over 500 physician from the Canadian Medical Society recently. And they identified two groups of individuals: EBM users, people who have been trained in some form of EBM, and non-users, more average clinician. And they found that the clinical experience, as appropriate, is a very high rate of the physician rely on clinical experience great deal, 90%. And next is a review article. This is a traditional review article published in medical textbooks and journals. And colleagues, they also consult colleagues very frequently, and textbook also another major source. And the research articles, original research article, EBM users having been trained actually to do that, more than twice of them also access this kind of article, and whereas non-EBM users don't use research article a lot. And CME, even though it's required, is not very useful, and also likewise clinical practice guidelines. Now, so for the printed medium, review articles and textbook represent the two most frequent source information that the clinician goes to for information. But how good are they? In this study, Cynthia Morrow, who's now an associate editor at the Annals of Internal Medicine, did a survey 15 years ago. She examined 50 review articles from 4 popular clinical journals over a 12-month period in the mid-1980s: the Annals of Internal Medicine, Archive of Internal Medicine, the JAMA, and New England Journal of Medicine. And then she looked at the following criteria: what the purpose, whether the author clearly stated what was the intent of this review article, what it's trying to do. And also, she also evaluated this article, whether the author identified where the data came from. That is, the references, the citations that the author made to support those statements. Did they tell you how did he or she selected them? And then whether they perform any kind of validity assessment on those references. And then did they provide any kind of qualitative synthesis of the multiple references? That is, this treatment overall works or doesn't work. Did they quantify the results? Did they provide some kind of summary of future direction? For the purpose, 40 out of 50, or 80%, did provide a purpose, but surprisingly, about 20% was not specified or was unclear. And what is most striking is only 1 out of 50 gave you some information about how they select, identify, and about the references, select citations, and also whether they perform any kind of validity assessment. They could choose any article and cite as reference, whether they're valid or not. And 43, about most of them, did provide some kind of qualitative synthesis, that is, this treatment does work, indeed works great. But only 3 out of 50 quantify this result, that is, they improve your outcome by 10%, 20%, for the accountability issue. And then, although 2/3 did provide a clear summary, but about a third of the time, summary were either unclear or not specified. And future direction about half and half. So the traditional narrative review articles or textbook chapters that clinicians rely on a lot is far from desirable. And as an example of this kind of fuzziness of the narrative review, this is based on an evidence report that our group did several years ago. This is a real paper. I blanked out the author's name in the journal to protect the identity. The duration of antibiotic treatment for acute sinusitis has not been clearly established, but recommendations vary from treating for 7 to 10 days beyond clinical improvement to simply treating for a total of 2 to 4 weeks. Your choice. If it is your choice, then why do you need to read their article? And this is a diagram showing the percentage of patients with acute otitis media given antibiotics or yeast infection. Most of this, all this is a westernized country, and most of them give around the same rate, 85 to 98%. But one country, Netherlands, gave patients only 31% of the time. Why this big difference? And if indeed, there's two hypotheses one can formulate. One is that either most of the countries gave antibiotics inappropriately most of the time, or doctors in Netherlands gave inappropriately too few antibiotics most of the times. And if that's the case, there should be differences in the outcomes. Either that, patients in Netherlands, many of them walking around with chronic ear problems, or we also have other unforeseen problems such as antibiotic resistance issues and so forth, and that you may not be able to know about easily. And so this kind of variation in how healthcare is practiced is well known. This is a concept by Jack Ware from Dartmouth, and this is published in USA Today several years ago, showing the rate of back surgery. The darker it is, the more higher rates of surgery. And as you can see, there's a lot of difference, heterogeneity across the entire United States. Why is this kind of pattern? Is it because the patients are different, or the doctors are different, or what? And this is a hip replacement, also showing somehow northwest part of the country do a lot more hip replacement surgery, except for Florida. Right? Florida, they kind of have a explanation. There's many elderly retired maybe there, and so that may be explainable. But why this dichotomy? And then for leg amputation, why is certain parts of Texas amputate patients' leg more readily than the rest of the country?
Rodeo.
What's that? Rodeo. And then partial mastectomy, and so forth. So this kind of variation of care, possibly is due to inadequate standardization of how things medicine should be practiced. Could be due to knowledge issue, and also information gets outdated, and so have people be updating information. And this is a diagram from Lancet several years ago showing this two authors try to estimate what is the half-life of truth in the medical literature. And one journal they look at is the Surgery, Gynecology, and Obstetrics. What they did, they took 260 abstracts, articles, and they took the single sentence that is most representative what this article is trying to say. And then they blinded this article and sentence and gave it to 7 general surgeons to have them rate them and whether this information is true or false. And not surprisingly, statements that back in the 1930s, 40s are very likely not to be true. Only about 15-20% to be true. And as more recent studies are more likely to be true. And so they did this kind of regression analysis, and they estimated in this journal the half-life of truth, or about half of the knowledge gets outdated in about 45 years. This is a surgical journal. But obviously information in different medical disciplines will vary. For example, for HIV infection, this is a rapidly evolving field, so therefore, at least in the past 10 years, sometimes information gets outdated within 6 months. So we do have this kind of phenomenon. Medical knowledge gets outdated, and it depends on the topics. The interval is different. As an example, 45 years ago, it was suggested that prefrontal lobotomy, taking out a piece of brain, usefully alter patients' reaction so that no anxiety, fear, or concern over the impending death from cancer was manifest. Well, while this may be true, but at least this is not a practice. And given there's so many different kinds of evidence, this is a hierarchy that various people have proposed. Starting with the lowest form of evidence, this is the anecdotal case report. And then you collect a bunch of cases to become case series without control. And then sometimes you can improve upon that to try to collect cases from history, or the so-called literature control, or historical control, and then also compare against what you have done 10 years ago to what you collected now, to make this kind of comparison. And then you can also collect a lot of cases using more structured, more rigorous collection in your computer, and then analyze it, this database. And then you can do more rigorous study design, so known as case-controlled study, and so forth. And then you advance to randomized control trials. This is experimental design. And then you confirm the randomized control trial, and then also by combining multiple studies together to give you meta-analysis, and then the meta-analysis of original data. Now, choosing the right study design is clearly important because of garbage in, garbage out phenomena. But the study design does not necessarily have to be randomized trial, and I'll show you a couple to illustrate this. This is a early clinical trial, N is equal to 2, just 2 subjects. In the late 18th century, King Gustav III of Sweden decided coffee was poison and ordered clinical trial. This is first printed in a Sweden journal and then reprinted in Annals of Internal Medicine. Study design, the king condemned the convicted murderer to drink coffee every day. The control with another murderer who condemned to drink tea every day. Outcome, the king wanted to assess was death, and the 2 physicians were appointed to determine the outcome. Result, the 2 doctors died at first. The king was murdered, and then both convicts enjoyed it long life until the tea drinker died at age 83, and no aid was given to the coffee drinker. And the discussion, one should not rely on such a small sample size, so the study design was bad, just too few subjects. And the endpoint maybe was too hard in this case, even though it's not clinical endpoint. And outcomes also no effect on the decision maker. Coffee was forbidden in Sweden twice. Conclusion, none possible. External event and other biases may have confounded the result, and the king should not mess with clinical trials. But another small study have a different impact. James Lind, a Scottish physician, about 250 years ago, on board of a ship, Her Majesty Salisbury, divided 12 sailors with scurvy into 6 groups of 2 sailors and given one of the following treatment: cider, elixir, victual, vinegar, seawater, nutmeg, or fresh fruits. And I think you know the rest of the story. Although this trial was done, although actually it did not have immediate impact. It took another about 50 years before fruits were given to sailors on board ships to prevent scurvy. So but this is a different story, different part of the story. It's about dissemination and of translating evidence into practice. Now, given all this information, there are a variety of ways of synthesizing information or evidence. Right? Talk about a little bit about the narrative review, the pros and cons, and I'm going to mention a little bit about systematic reviews and meta-analysis later. This is not about decision analysis and other things, so let's to skip that. Although just to mention that this names, there are other ways of combining information. A systematic review or a narrative review, as the principle is shown on the left, it generally gives a panoramic view, that is, it covers the whole topic about, such as in the textbook chapter, emphasize background information about the disease, the prevalence, the etiologies, and pathology, and so forth. What causes disorder, what are the clinical manifestations, what treatment options are available. They're susceptible to bias in selecting, appraising, and combining studies to answer questions. I demonstrate this in Cynthia Moreau's review. In a systematic review, contrast with a narrative review, they examine more telescopic views, that is, only a question or few questions at a time, and focus on the foreground knowledge. For example, in the treating patients with this disorder, which of the 2 available treatment is better at improving clinical outcomes safely? So the question it asks is more specific, more focused. And then uses rigorous methods to minimize bias, to identify the studies, to collect them, and to critically appraise them in order to help improve the reliability and the accuracy of the conclusions. And then frequently, systematic review, if data is available, can also be combined with the data to form a meta-analysis. So given the universe, all the review articles, systematic review can, you can kind of think of this as a subset of all the review articles. And then when appropriate data is available, quantitative analysis, statistical analysis can be done on those studies to produce meta-analysis. So meta-analysis is a subset of systematic reviews. There's a few other names of meta-analysis. Quantitative overview, it's a subset of systematic review. It's a scientific discipline which applies a protocol to critically evaluate and then uses statistical methods to combine the results, most of the time of previous research. And it can provide a quantitative summary of the overall treatment effect. This improves the outcome by a certain percentage and so forth, and also give you an estimate and some degree of confidence interval or measure of variability, a range of uncertainty. And also increasingly, through the methods of meta-analysis, can also be tried to understand differences among studies in order to explain discrepancy of results and also to generate hypotheses of interaction. And what is all this long words means is try to understand why one drug works better than one set and another. I think Lou tried to allude to this later also by the pharmacogenomics, that some patients respond to treatment better than others and get more side effects than others. And sometimes you can know about this through clinical features of patients, but they may not be as well predicted than pharmacogenomics. But again, that will be in the future. And also meta-analysis by assembling a collection of studies, also by identifying gaps of knowledge, can also be used to guide future research. And so in doing meta-analysis, this kind of a black box approach, you have a question you want to answer. You do a meta-analysis, you get an answer. But within the meta-analysis, this is black box, there are a number of steps must be carried through. You need to refine your question. Then you need to retrieve the studies that address that question. And then you need to critically appraise those studies, and then select a study, use it, and analyze them, perform data extraction, analyze them, and then interpret the results. Meta-analysis has been applied to several major clinical areas, to interventions, that is to find out whether treatment works or not, as well as to find the risk of treatments. But also meta-analysis is not just restricted to interventions. Also can be performed on diagnostic tests, try to figure out whether a certain test is more reliable, provide better accuracy, and also to epidemiology to better understand association of risk or correlation of risk to a certain outcome. And also meta-analysis of intervention is not just restricted to randomized trial. Although obviously the better the study design you have, the more reliable will be your conclusion. If you look at poor study qualities, you still will end up with not so great results. The benefit of meta-analysis is that it can provide a more precise estimate of results. I will demonstrate this. And also by quantifying the results, you can now also make comparisons across different alternatives. Without quantification, it's very more difficult. And it can help to decide when there is sufficient evidence. So therefore, no more study is needed. And statistical analysis can be done to understand why study results differ. And then cost-effective analyses could also be performed using this data from meta-analysis in order to form a policy decision-making, such as say for insurance purpose. As an example of a meta-analysis, this is one that my colleagues and I worked on, published in the British Medical Journal several years ago. The topic question here is that whether once daily dose of aminoglycoside and antibiotics is just as good as multiple doses given a day. And at that time, there were some studies, human study as well as animal study, suggesting that single daily is just as efficacious. But no one, I guess, would believe it because either the study is too small or inconclusive. And so we identified this collection of studies, about 16 or so studies, and that's from a literature search. And this is what a typical meta-analysis may look like. The scale here is a risk ratio scale. 1 means no difference between a treatment, in this case, single daily doses, versus on the other side, multiple daily doses. So risk ratio here, the black dot, and then with the bar, so-called 95% confidence interval. If the 95% confidence interval does not cross midline or 1, it means it's statistically significant. So therefore, the first study is statistically significant in favor of multiple daily doses of aminoglycoside. But then the second study is an opposite side, in favor of single daily doses. And then the third study is not statistically significant as a trend in favor of multiple daily doses. And so you have this kind of back and forth pattern. Not surprisingly, that it confuses many people when they look at this body of evidence. The evidence seems to go back and forth. And occasionally you have another study that's significant, but then occasionally then you have more study of a trend on opposite side. So what conclusion should one draw? If you believe all these studies are addressing the same issue, then we can combine them. Because one belief is that some of these variations of estimate is just due to chance. Because when you do an experiment, there is this chance of certain things happening, and then within a certain range, and this is what a 95% confidence interval means, the result could actually occur in any of those places along the confidence interval. And so by doing a meta-analysis, we combine all the studies and give you one result. And now it depends on what statistical method I'm going to get into, but both of them give you very similar estimate on the same side. That is, the trend at least, that single doses of aminoglycoside is as efficacious, if not more so, than multiple daily doses. And the outcome here is clinical failure. So therefore, the one interpretation of this analysis result would be that single daily doses is just as good, if not better. And then we also examine a toxicity outcome. Similarly, this is for kidney toxicity. Similarly, this is a kind of back and forth pattern, difficult to appreciate. When you combine all the study, we also find that single daily doses also reduces nephrotoxicity. And this is what also animal models demonstrate. So now around the same time that we published our study in '96, 10 other groups of authors also published this did this analysis on the aminoglycoside, showing you that this is a clearly interesting topic, a hot topic at that time. And different groups end up with different number of studies in the meta-analysis, either based on the protocol inclusion-exclusion criteria defined. And some, for example, some include all comers, some only study immunocompetent patients, some immunocompromised patients. But all these studies basically show the similar result, that the single daily doses of aminoglycoside is just as good. And so that led to editorial that meta-analyses are no longer required for determining the efficacy of aminoglycoside, a single dose glycoside. And that this body of data now exists, including pharmacodynamic studies, animal infection models, human comparative trials, and literature meta-analyses to support the practice of once daily dose of aminoglycoside. This is some data that I collected 8 years ago now, showing the growth of meta-analysis of a randomized control trial, showing that not a lot of action before 1980s, and since the mid-1980s, there's been growth has been very rapid. And also this is the same period, showing that meta-analysis cover a broad range of topics. Cardiovascular led the way in the mid-19 up to 1990s. And if you do a more updated search, you will see that virtually all areas in clinical medicine, including pain. Actually, there are numerous meta-analyses now published in pain, and surgery, mental health, dentistry, and many surgical subspecialty have also published meta-analyses. So it's no longer a selected medical fields. And also meta-analyses are published not in throwaway journals. Most of meta-analyses have been published in high-impact journals: Lancet, JAMA, Annals of Internal Medicine, American Journal of Medicine, British Medical Journal Circulation, New England Journal of Medicine, etc. In a more recent survey I did, over 600 biomedical journals now published meta-analyses. Okay, one of the topic many years ago that when I was starting this field was what to do with meta-analysis when a new randomized trial appeared. And the example I'm going to be showing is a field of acute myocardial infarction or heart attack. And the articles were published in New England Journal of Medicine '92, along with the late Tom Chalmers and also Fred Marstauer, who's a important figure in statistics, biostatistics, and Tom Chalmers is one of the founding figure in meta-analysis in medicine. And the idea is that we will have studies. We could arrange it chronologically, but this so-called cumulative meta-analysis can also be ordered by other things, which I will not get into. So we're interested right now looking at study, ordering them by their publication year: early study, later study. So we'll combine the first two studies, give you the first cumulative meta-analysis result. And then next we will combine the first three studies, give you the next cumulative meta-analysis, and so on. So with n number of studies, we have n minus 1 cumulative meta-analysis, or kind of like a running total, if you will. This is better looked at graphically. So this topic is use of intravenous streptokinase in acute myocardial infarction. Or this is one of the blockbuster drugs that also we'll refer to. But it was not known as a blockbuster initially. It took many years before recognition. The first streptokinase trial was published in 1959, 23 patients, and overall odds ratio mortality reduction, again, 1 means there's no benefit. Left of 1 means there's a favors treatment or placebo on the right. So the first study was not statistically significant because the confidence interval did not exclude 1. And the second study also not statistically significant, but both has a trend, favoring streptokinase. But the third study has a trend favoring control. And then the first study is statistically significant in favor of streptokinase, but then more study was negative. Now most of this statistically non-significant study in the past was known as negative trial. But they're not really negative. They have the trend in one direction or another. And but so we have a lot of back and forth. Occasionally significant study, and then in 1986 you have a very large study, almost 12,000 patients. This so-called GC1, or known as mega trial, was highly statistically significant. Followed 2 years later by another very large study, ISIS-2, in 1988, 17,000, highly significant. And when you combine all this study together, you have highly statistically significant result. You have 33 studies involving 37,000 patients. So that's kind of not surprising. And FDA approved this drug in 1988, primarily after those two very large trials were done. Because there's a requirement that you must have two well-conducted trials that's statistically significant in order to approve medication, a new drug. Now, if you look at cumulative meta-analysis, the scale here has been expanded, so 0.5 to 2 has been shown, so you can see greater detail. So by combining the first two studies, we'll have 65 patients, the first cumulative meta-analysis result, and then combine the three. So not surprisingly, this is a negative study, so we'll move the estimate closer to no effect. So as you combine more study, this estimate, this black dot, kind of stabilize, pretty much, hovering around the same spot. And then the confidence interval just progressively narrow as you get more patients, more study, more statistical significant. And then in 1973, after 8 studies and about 2,400 patients, we have a first statistical significant, and then it stayed so. And adding more study did not change the statistical significant conclusion. And the estimate also, but how much it saved lives by didn't change much. It just getting more and more precise. And even by adding those 2 mega trials, very large study, the jump, the estimate really did not change. It was this precision change, and even more precise, or in statistical jargon, become more powerful result. And so, through hindsight, by looking at cumulative meta-analysis, one can now say that, gee, back in 1973, we could have, through a retrospectoscope, that this treatment is efficacious in saving lives. And yet, FDA had to wait until 1985, 88, 15 years, lacking in recognition that this drug, this class of drug, could be efficacious in saving lives. And this kind of back and forth, perhaps this quote from Mark Twain is quite appropriate. That the research of many commentators have already thrown much darkness on this subject, and it is probable that if they continue, we shall soon know nothing more about it. But then also there's a dark side to this, that is, when we do clinical trial, we are enrolling subjects to the placebo group. And if we know that patient could respond to treatment, we should not be subjecting them to control that doesn't work. And this also may be applied to pain studies as well. And this is a comparison of the thrombolytic therapy with a textbook and review recommendation. And instead of the 33 streptokinase, we also now combine the other class of thrombolytic drugs because they all behave the same way, so we just combined that. So instead of just 33 studies and 37,000 patients, now we have 70 studies and 48,000 patients. And the cumulative meta-analysis looks very similar. So also by 1973, now it's 10 studies, 2,500 patients. A statistically significant result could have been achieved. Adding more study did not change the statistically significant conclusion. So look at the recommendation from textbook and review authors. We categorize them into 5 categories. Routine, specific instances, rare, never to be used, experimental setting, and not mentioned at all. Early on, even though there have been quite a handful of studies being available, then only occasional author mentioned this as an experimental treatment. And there was no mention that this should be used, even though that if we have done a meta-analysis back in 73, could have demonstrated efficacy of this treatment. And actually, the first meta-analysis was published around this time in late 1970s. And then in the early 80s, then there's occasional recommendation that it can be used in specific circumstances. And again, not until the very large trial, 86 and 88, were published, and also FDA approval did a recommendation. Authors begin to recommend this, shift their opinions over. And there's a number of issues which I'm not going to have time to discuss this further, but I can give the references to these papers would be interesting reading. This is a note to myself. Yes, it's past 7:15, so I have to skip to formulating question. I did not speak fast enough.
Very good. So I didn't break into your computer.
Okay, I just wanted to mention a few things about, because what I have discussed is just a very generality issue without you having any practical take home. So I'm going to give you a few things that you can take away that will still be useful. In forming a systematic review protocol, as I mentioned, one of the most critical part of it is to formulate the study question, research question. And then you identify the studies, establish the eligibility criteria, perform data extraction, and then summary and final analysis. So what I'm going to talk about primarily is about a focused question. And also these are the different components of doing a meta-analysis or systematic review. Each of the aspect involve approximately the same amount of effort. And a typical systematic review meta-analysis, depending on the size of it, may be from at least several months to at least a year or longer. So it's not a trivial pursuit. Asking the right question is always important. And here, executioner asks paper or plastic. To the person who executed it, it probably doesn't matter. And that's now defining what you mean is very important in a question, because language is ambiguous. And I'm going to use example from a political incident from several years ago. This is an article from the JAMA, 1999, and this article was published by these two authors, and that resulted also in the editor of the JAMA journal fired. I don't know whether many of you recall that incident. It's been made in the news media. And this also occurred around the ex-president Bill Clinton's scandal. This study, I'm going to highlight the issue. The objective was to determine, the two authors were a psychology professor at a Midwestern State University. Objective was to determine which interaction individual would consider as having sex. And this is actually valid medical question, because as clinicians, clinician has to ask the patients about their sexual behavior in order to understand the risk. And so just ask the question, have you had sex? What does that mean? And so this survey of 600 undergrad students, 80% self-rated as political moderate conservative, gave these answers. And I'm going to highlight a few. From kissing through intercourse. And the men and women track fairly closely, kissing, involving very low percentage, and sexual intercourse almost 100%. But then you may also ask why this is not 100%. And through the other sexual context, different percentage of men and women respond as this means having sex. So if a doctor just asks a question to a patient, you will get very different meaning, and from the patient. And to kind of illustrate graphically, this is a letter to the Boston Globe by Zig Rubin, who's also a psychology professor, but now since then, this publication is a lawyer. In this letter to the Boston Globe, he produced this graph: sexual scale, relationship scale, -10 to +10, -10 to +10, to help you to get some meaning for this scale. Going on dates. First time going on date, coffee. This is a hypothetical date. Second date, bowling. So there is a change in the sexuality and the relationship meaning of it. The third date, movie. Fourth date, driving. Fifth date, VCR. And also some other international calibration. Queen Elizabeth and Prince Philip is a -8 on the sexual scale, and -1 is on the relationship scale. And then there are others. And so when, for example, when Bill Clinton said, "I never had a sexual relationship with this woman," where does it lie? And so therefore, it leaves open to interpretation. So similarly, for medical diagnoses, conditions, we're faced with similar kinds of issues. That is, the diagnosis often have different degree of rigor, different definitions, and some of them they may not even have a good reference standard. And the definition of different levels of rigor, and also sometimes there's a reason for that is practicality, trade-off between rigor and the real-world practice. For example, to diagnose whether you have acute sinusitis, how should doctors do that? The reference standard to do that is stick a needle into your sinus and aspirate some pus and examine it. But who would want it to be done? And so most of the time it's based on clinical examination and history, and maybe occasionally going to X-ray. So therefore, the accuracy of that is going to vary. And this is a picture of a CT with opacify the sinus, and so you have duration of symptoms. Could be less than 2 weeks, 3 weeks, 4 weeks. The longer duration, perhaps more likely. This is a true bacterial infection, not just a common cold or a allergy. And then diagnostic criteria, there's been rigor. There's sinus puncture gives you more likely or X-ray finding or clinical finding. And then sinus puncture will be more likely to be a real bacterial infection, whereas clinical diagnosis and radiographic more likely to end up with virus infection. So, as an example of, for example, what is a not well formulated question? This would be a question that may be asked. What is the role of TENS in the management of post-op pain? What's wrong with this question? Right. Well, how would you rephrase that? Well, this is one possible scenario rephrasing the more focused question. Will be, does TENS therapy decrease post-op pain and medication needs in adult patients undergoing elective surgery? Now, there are 4 major ideas that a well-focused question must encompass. What is the intervention? And then also, you need to spell out very clearly what is the nature of intervention. For example, here the TENS may need to be very specified. What's the rate of the electrical pulses, the pulse width, the pulse amplitude, and so forth. What make of the machine, and so forth. And outcome. What do I mean by outcomes? Here is post-op pain and medication needs. And then post-op pain, how do you measure that? Visual analog scale, and then also medication needs. What kind of medication? Should it be NSAIDs or narcotics? And complications. And also post-op, what does it mean by post-op? How many days? And then the population settings, what kind of patient? Should be adults? And then condition of interest, elective surgery, what does it mean by elective surgery, and so forth. So within each of the major ideas, you also need to more clearly specify that. So this is what a well-formulated research question should include. So I'm going to end up by just commenting a few ideas about the evidence-based medicine. The strength of evidence-based medicine is that it helps to reduce uncertainty and make the best use of existing knowledge. And some argue that it can be performed by practitioners on the job. I'd say maybe that is, it's not quite easy to be practicing evidence-based medicine on the job. That is, if you're seeing a patient, you may not have the time. Right now, it takes time to look up things and have computer access, and the evidence has to be there, and frequently they're not. So there may not be a lot of evidence. And there's also, there are not a lot of good evidence, and also not a lot of good evidence that's generalizable from a population to population. There are a limited number of studies that have been done on any clinical topic. And there are not a lot of generalizable evidence population to individual. That is, studies in randomized trial is done in a cohort, a group of patients. And what you need to do when you treat the individual, the specific characteristics. And again, when you mentioned earlier about the genomic, pharmacogenomic, this is would be the how to treat individual. And also, EBM needs training. You need to how to interpret results, how to access them, and also need time to learn and use the skills. And then also to practicing the EBM, you also, who cares? And then I mentioned that you need resources, and often there may not be evidence, with cause of disappointment. But the important thing is that takeaway is that EBM is not about corporal medicine. It's not cost-cutting medicine, and nor is it a substitute for clinical experience. It complements clinical experience, and it's not restricted to randomized control trial or meta-analyses. And and finally, what we are after in evidence-based medicine is make better clinical decisions, where evidence is only one component of this process. Other things that we need to know about is understand, appreciate the patient-physician factors, knowing about a patient's cultural beliefs, personal values, and then also the constraints, that is, within the local practice, what are the policies, community standards, reimbursement policies, and also the amount of time available. And so there's the overlap of the various things that give you a lot, helps you to make the clinical decisions. That's all I want to say, and now happy to answer any questions.
Should EBM representatives make visits to primary care physicians' offices very much? In the most recent,
Yeah, well,
the most recent findings.
Well, there is, I don't think, since this EBM is a non-profit entity, no, as Luz mentioned, that pharmaceutical company want to sell drugs to lots of people, not only to subgroups. So likewise, to better understand how to use drugs is not to their interest. They just want to sell it. So
If no other questions, well, thank you, Joseph, for coming by and spending a lot of good time.